She came in on a Thursday afternoon, and the first thing she did when she sat down was take off her shoe. Not because I asked her to, because her foot had been bothering her for so long that removing the shoe had become a reflex, something she did every time she sat down anywhere. Her name was Pauline. She was 73 years old. A retired postal clerk who had spent 31 years on her feet delivering mail in a mid-sized Ohio town, and she was proud of that. I walked more miles than most people drive, she told me. The reason she was in my office that day was not her foot. She had come in for a routine blood pressure review, but I noticed the shoe. I noticed the way she shifted her weight, and when I asked her directly about her feet, she described something she had been living with for over a year, a persistent tingling in both feet, worse at night, that she had attributed entirely to all those decades of walking. Her fasting blood sugar that morning was 231. She had type 2. Diabetes, had almost certainly had it for at least 2 years, and her feet had been telling her that story every single night while she lay in bed trying to sleep. I am Dr. Pablo. I have spent 18 years practicing geriatric medicine with a focus on cardiovascular health in adults over 60, and I want to tell you something that most people in my field do not say clearly enough. Diabetes does not begin with a blood test. It begins in your body, sometimes years before any laboratory result confirms it, and it announces itself in ways that are entirely visible if you know what you are looking for. The place it speaks first, and speaks most consistently, is your feet. Today I am going to walk you through 9 signs that your feet may already be showing you, signs that your blood sugar has been elevated long enough to begin causing real, measurable damage to your nerves, your blood vessels, and the tissue that depends on both. For each one I will tell you what is actually happening inside your body. At the cellular level, what the research says, and one concrete protective habit you can begin today. And I want to tell you now, before we begin, that the sign I am placing at number 1, the last one we discuss, is the one that concerns me most as a clinician, not because it is the most painful, but because it is the most silent. It is the one that has already been present for years in patients who walk into my office convinced that nothing is wrong. So stay with me through all 9. That final sign is the one that changes how you will look at your own legs for the rest of your life. Before I get into the signs themselves, I need to give you a brief explanation of why the feet are where this story begins, because understanding this will make everything else I tell you today make sense in a way it otherwise would not. Your feet are the furthest point in your body from your heart. The blood vessels supplying your feet, particularly the smallest ones, the ones we call the microvasculature, are extraordinarily fine and delicate. When blood sugar remains elevated over months and years, glucose molecules attach to the walls of these tiny vessels and begin to damage them from the inside. The vessel walls thicken and stiffen. The passages narrow, blood flow to the feet diminishes. At the same time, the nerves that run from your spinal cord all the way down to your toes, the longest nerve fibers in your body, are particularly vulnerable to elevated glucose. Sugar attacks the protective sheath surrounding these nerve fibers, the myelin, and disrupts the electrical signals that those nerves are responsible for transmitting. The result is a combination of vascular damage and nerve damage that shows up first, and most clearly, in your feet. This is not a coincidence of anatomy. This is your body's geography working against you when blood sugar is out of control. Sign number 9. And I want to begin here because this is the sign that almost every patient I have ever discussed it with has already experienced and already explained away, often dozens of times, before they ever mentioned it to a physician. You feel it most often in the evening, or when you sit still for too long, or when you first put your feet up at the end of the day. A tingling, a faint buzzing, the sensation that your foot has fallen asleep even though you have not been sitting in a position that would cause that. Your foot is not asleep. Your nerves are being damaged. What is happening is this. The nerve fibers in your feet, the ones responsible for transmitting sensory signals, temperature, touch, pressure, position, are being slowly stripped of their protective myelin sheath by chronically elevated blood sugar. The myelin is the insulating layer around the nerve fiber, the material that allows electrical signals to travel cleanly and efficiently from your foot to your brain. When that insulation is degraded, signals become distorted. Your brain receives incomplete, scrambled information from your foot. The result is tingling, buzzing, or the pins and needles sensation that seems to appear without a clear cause. I describe it to my patients this way. Think of a fiber optic cable. The light signals inside travel cleanly because the cable is intact. Now imagine someone has been slowly scratching the surface of that cable every day for 2 years. The signal does not cut out entirely at first. it just gets noisy. The tingling in your feet is noise in the signal. It is the sound of a nerve that has been quietly scratched for longer than you know. The American Diabetes Association reports that peripheral neuropathy nerve damage of the kind I am describing affects nearly half of all people with diabetes, and that in the majority of cases it begins in the feet, often years before a formal diagnosis is made. That means right now, in the United States alone, millions of people are feeling this tingling and calling it nothing. My recommendation, and this applies to every point I make today because it addresses the root, a 30-minute walk every single day, not aggressive exercise. A walk, regular physical movement improves insulin sensitivity, keeps blood flowing actively to the feet, and slows the progression of nerve damage measurably. Start reducing added sugar today, not gradually, not eventually today. The nerve damage I am describing is dose-dependent. Every day of elevated blood sugar is another day of quiet, cumulative damage. Sign number 8. My patients almost universally bring this one up reluctantly, and only at night, because that is the only time it is bad enough that they cannot ignore it. During the day there are distractions, grandchildren, errands, the television. At 2 in the morning, lying in the dark, there is nothing between you and the burning in the soles of your feet. Burning foot pain at night is one of the most classically described early symptoms of diabetic neuropathy, and the physiological explanation for it is both remarkable and deeply uncomfortable to contemplate. The nerve fibers in your feet have been damaged by elevated glucose, but damaged nerves do not simply go quiet, they misfire. They send signals to your brain that the brain interprets as tore pain even when nothing externally hot or painful is touching your foot. Your nervous system in this state is like a smoke alarm with a corroded sensor. The building is not on fire, but the alarm cannot tell the difference anymore. Research published in the journal Diabetes Care established that burning foot pain is among the earliest reported symptoms in patients who are later formally diagnosed with type 2 diabetes, frequently presenting between 1 and 3 years before any blood test confirms the diagnosis. 1, 2, 3 years. That is how long this signal can be present and ignored before anyone acts on it. Howard was 67 years old, a retired high school football coach from rural Tennessee, a man who had spent 40 years telling young men to push through discomfort. He applied the same philosophy to the burning in his feet. He told me he had been waking up at night for 18 months and putting his feet on the cold tile floor of his bathroom for relief. Cold tile on the soles of the feet. That is the home remedy of a man whose nerves have been misfiring for a very long time. His HbA1c, the blood marker that reflects average blood sugar over 3 months, was 9.2. He had been diabetic for what his clinical picture suggested was close to 3 years. 2 habits for this sign specifically. First, 8 glasses of water every day. Hydration supports kidney function, and your kidneys are responsible for clearing excess glucose from your bloodstream. Second, add fiber to every meal: vegetables, legumes, whole oats. Fiber slows the absorption of glucose after eating, which is precisely what those damaged nerves need. Fewer spikes, less sustained elevation, less ongoing damage. Sign number 7. And I need you to pay very close attention here, because this is the point at which the story of your feet stops being about discomfort and starts being about danger. This is the sign that sends more of my patients to vascular surgeons and wound care specialists than any other on this list. You have a small wound on your foot, a blister from a shoe that rubbed wrong, a shallow cut from walking barefoot, a crack in the skin of your heel that bled slightly and then seemed to stop, and it has been there for 3 weeks, 4 weeks. You keep waiting for it to close on its own the way every other small wound in your life has closed, and it is not closing. When blood sugar is chronically elevated, 2 simultaneous processes compromise wound healing in the feet. First, the blood vessels supplying the foot have narrowed and stiffened, so the delivery of oxygen, immune cells, and the protein components needed to rebuild tissue is significantly slowed. Second, the immune response itself is impaired. Elevated glucose directly suppresses the function of the white blood cells responsible for fighting infection at the wound site. The wound sits open, bacteria colonize it, and in a foot with compromised circulation and impaired immunity, what begins as a blister can become an ulcer, and what begins as an ulcer can become a surgical emergency. The Centers for Disease Control has reported that diabetic foot ulcers are the leading cause of non-traumatic lower limb amputations in the United States, accounting for more than 100,000 procedures annually, and the overwhelming majority of those amputations were preceded by a wound that was small, that was noticed, and That was not brought to medical attention within the window when intervention was still simple. Tonight, after your bath or shower, sit down with good light and examine both feet completely. Look at every toe, between every toe, across the sole, the heel, the ankle. If you find any broken skin, any cut, blister, crack, or abrasion, clean it gently with mild soap and water, apply an antiseptic, and cover it, if it has not shown clear improvement within 48 hours, call your doctor. Not at your next scheduled appointment, call within 48 hours. Sign number 6. This one is visible every single day, and almost no one recognizes it for what it is. It has probably been there for months, perhaps longer, and you have walked past it in the mirror every morning attributing it to sun exposure, or dry skin, or simply the natural appearance of aging skin. Look at your ankles. Look at the skin of your lower legs just above the ankle. What you are looking for is a change in color, a deepening, a reddish or brownish discoloration, or in more advanced cases a faint bluish tint to the skin in that specific region. When blood circulation to the lower extremities is impaired by blood vessel damage from chronic high blood sugar, the skin of the lower leg and ankle is among the first places where that impaired circulation becomes externally visible. Oxygenated blood is not reaching this tissue in sufficient volume. The skin changes color as a result. In some patients, the skin in this region also becomes thinner, more fragile, more prone to tearing from minor contact. These are not cosmetic changes. They are the external face of vascular damage happening in the tissue below. I use this image with my patients. Your blood is a delivery system. Your feet are at the end of the longest supply route in your body. When the roads narrow, when the blood vessels constrict and stiffen from glucose damage, the deliveries arrive late and incomplete. The skin, waiting for oxygen that is not coming on schedule, sends up a visible distress signal. That discoloration around your ankles is that signal. A study published in the Journal of the American Academy of Dermatology found that these specific lower extremity skin changes were detectable on average approximately 18 months before a formal diabetes diagnosis in the patients studied, 18 months of a visible sign that was present and unrecognized. 5 minutes of ankle circles, toe raises, and calf stretches every morning before you get out of bed. Even that small amount of targeted movement drives blood actively into the vessels of your lower legs and feet. If mobility limits your ability to exercise, elevating your feet slightly while seated, even a folded blanket under the ankles, supports venous return and reduces the pooling that worsens these changes. Sign number 5. And this one surprises my patients more than almost any other because it looks, on its surface, like something entirely mundane. You have seen it on your own feet and thought nothing of it. Your heels crack. The skin on your heels becomes thick, dry, hard, and then splits. You apply lotion. You use a pumice stone. You buy the special creams they sell at the pharmacy. Nothing works for long, and you have concluded that you simply have dry skin, that this is a minor cosmetic inconvenience, and that it is unrelated to anything serious. Here is what is actually happening. Your body regulates the moisture content of your skin through a network of autonomic nerves, the part of the nervous system that controls automatic, unconscious functions, including the activity of the sweat glands in your feet. When elevated blood sugar damages these autonomic nerve fibers, the sweat glands in your feet stop functioning normally. Your feet lose their natural moisture from within. The skin becomes dry not because of what you are putting on the outside, but because the internal system that keeps it hydrated has been disrupted. No external moisturizer addresses this root cause. And cracked skin on the heel is not a cosmetic problem. It is an open door for bacteria in a foot that already has impaired circulation and impaired immune response. The American Podiatric Medical Association identifies persistent, treatment-resistant heel cracking as a recognized clinical indicator of autonomic neuropathy in older adults. Nerve damage to the involuntary nervous system caused by long-term elevated blood sugar. Moisturize your feet every night before bed. A thick urea-based cream or pure coconut oil applied to the soles and heels. Apply thoroughly to those surfaces, but never between the toes. Moisture trapped between the toes creates the warm, dark, damp environment in which fungal infections thrive, and drink your 8 glasses of water daily. Hydration from within matters as much as anything you apply from the outside. I want to stop here for a moment because we are halfway through, and I want to ask you something directly. Have you recognized anything I have described so far in your own feet or in the feet of someone you love? A spouse who complains about burning at night, a parent whose ankles have been discolored for years, a sibling who has had a wound that will not close. Go to the comments right now and write your age and tell me where in the world you are watching from. Write your city, your state, your country. I read every comment on this channel. Every single one. You are not a passive viewer to me. You are exactly the person I created this channel to speak to. And if this information is reaching you when it matters, I want to know that. Sign number 4. And I want you to hear this one carefully, because it is the sign that most commonly gets men into serious trouble. Not because it is more dangerous than the others in isolation, but because of how effectively it gets misattributed and because of how long men in particular will manage a misattributed symptom on their own before they say a word to anyone. You have pain in your foot, not the tingling, not the burning actual pain, stabbing, sometimes, a sharp, electric quality, or deep and aching in a way that feels like it is coming from the bone. It is worst at night. You have been taking ibuprofen for it for months. You are certain it is an old injury, an arthritic joint, a tendon that never quite healed, and the ibuprofen takes the edge off enough that you have stopped asking what is actually causing it. When nerve fibers are damaged by chronic glucose exposure, they do not all respond the same way. Some go quiet, producing the numbness and tingling I described earlier, but others become hyperactive. They fire continuously and randomly, sending pain signals to the brain in the absence of any external injury or stimulus. The pain is entirely real. It is not imagined. It is not psychological, but its source is inside the nerve itself, which is misfiring the way a car alarm fires after a minor collision long after the cause has passed. Taking ibuprofen for this pain is the equivalent of pulling the battery out of that alarm. You have silenced the signal without addressing what triggered it, and the damage continues. A landmark study in the New England Journal of Medicine found that painful diabetic neuropathy affects approximately 25% of people with diabetes and is misdiagnosed as arthritis, tendinitis, or age-related joint degeneration in a substantial proportion of cases, 25%, that is 1 in 4, and each of those patients, in the time between the onset of the pain and the correct diagnosis, has been suppressing a signal their nervous system was sending for a reason. Raymond was 69, a retired plumber from outside Philadelphia who had been managing what he called a bad ankle with over-the-counter anti-inflammatories for the better part of a year. He was a quiet man who did not like to make a fuss. He came to see me because his wife had told him she would drive him there herself if he did not make the appointment. His nerve conduction study was significantly abnormal. His blood sugar had been elevated for what the clinical picture suggested was close to 3 years. The ankle was not the problem. The ankle was the messenger, and the messenger had been medicated into silence while the problem continued uninterrupted. Every morning, before you put weight on your feet, 5 minutes of gentle foot and ankle mobility. Flex your feet, circle your ankles slowly in both directions, pull your toes back toward your shin gently. Get circulation moving into that tissue before you load it with your body weight. And every evening, a gentle 3 to 5 minute massage of the soles and ankles, light circular pressure, working from the ball of the foot toward the heel and up the ankle, not vigorous, not deep, gentle and consistent. Sign number 3, and this one I find particularly important to discuss with my patients in the context of cardiovascular health, because what is happening in the feet when you see this sign is directly related to what may be happening in the blood vessels of your heart and your brain at the same time. Your feet are cold, not cold, because the room is cold. Cold when the room is warm, cold under 2 blankets, cold in July while the rest of your body is comfortable. A persistent, irresolvable coldness in the feet that does not respond to warmth the way cold feet should. When blood sugar damages blood vessels over time, the damage is not limited to the microvasculature, the tiny vessels, though those are affected first. It extends to the medium and larger vessels as well. The arteries supplying the lower extremities narrow and stiffen through a process called atherosclerosis, which is accelerated dramatically by chronic high blood sugar. As these arteries narrow, they deliver less warm, oxygenated blood to the feet. The feet become cold because the furnace, the heart, is working, but the pipes are too narrow to carry sufficient heat to the far end of the system. The American Heart Association identifies peripheral artery disease, the narrowing of the arteries supplying the legs and feet, as affecting over 8 million Americans, with diabetes being the single largest modifiable risk factor. And I want to be explicit about something here, because this is the cardiovascular connection that makes this sign particularly significant for my patients. The same atherosclerotic process that is narrowing the arteries in your feet is almost certainly narrowing arteries elsewhere in your body, including the arteries that supply your heart and brain. Cold feet from peripheral artery disease are not just a foot problem. They are a window into your systemic vascular health. A 30-minute purposeful walk every single day is the most evidence-supported intervention available for early peripheral artery disease. Not a casual stroll, a brisk, arm-swinging walk that elevates your heart rate. This drives blood flow actively into the peripheral vessels, stimulates the growth of collateral circulation, small new vessel pathways, and slows the progression of arterial narrowing measurably. Begin with 10 minutes if 30 feels like too much today. The direction matters more than the distance. Sign number 2. This one I want to address carefully, because it occupies an interesting space between the cosmetic and the clinical, and patients almost never bring it to my attention because they do not think it belongs in a medical conversation. But I ask about it specifically, and when I find it, it tells me something important about the duration and severity of what the rest of the examination has already suggested. Look at your feet and lower legs. Look at the tops of your feet and the skin of your lower legs between the ankle and the knee. Is there hair there? Less than there used to be. Absent in patches or entirely. Hair follicles, like every other living structure in your skin, require a continuous, adequate supply of oxygenated blood to function. When circulation to the lower extremities is significantly compromised, when the blood vessels have narrowed to the point that oxygen delivery is genuinely insufficient, the hair follicles in the affected region stop receiving what they need to sustain growth. Over time they become dormant. The hair thins. Eventually, in areas of most severe circulatory compromise, it disappears entirely. This is not alopecia. This is not aging. This is a visible marker of blood vessel damage, potentially years in the making, printed on the surface of your skin where anyone who knows to look can see it. Research published in the journal Diabetes, Obesity and Metabolism found that lower extremity hair loss correlates significantly with peripheral vascular disease in patients with elevated blood sugar, and that physicians trained in diabetic foot assessment specifically use this sign as a clinical indicator of the severity and duration of circulatory compromise. The absence of hair on your lower legs is not trivial. It is the skin's way of telling you that the blood supply to this territory has been inadequate for long enough that biological processes that require steady circulation have quietly shut down. The protective response here begins with the walk I have already described. Daily movement is the most powerful tool available for maintaining peripheral circulation, but this sign in particular, when present, is one I consider a strong signal to pursue formal evaluation. A simple ankle brachial index test, a non-invasive blood pressure comparison between the ankle and the arm that takes about 10 minutes in a physician's office can quantify the degree of peripheral arterial compromise with great accuracy. If you look at your lower legs today and the hair is significantly diminished or absent, and you have not had this evaluated, please make that appointment. And now sign number 1, the one I have been building toward, the one I placed last not for dramatic effect, but because I genuinely believe it is the most important and the most universally overlooked. And the reason it is so overlooked is that it is not something you feel, it is something you see if you look, and the tragedy of it is that most people either do not look or look and see nothing, because they do not know what absence looks like when absence is the sign. You look at your feet, both feet, you look at the nails, and what I need you to look for is this: a specific pattern of thickening, discoloration, or brittleness in the toenails, particularly combined with a slow or absent growth rate that may have been changing so gradually you genuinely did not notice it was different from what it once was. Toenail changes in the context of poorly controlled or undiagnosed blood sugar are driven by two converging processes. First, the same circulatory compromise I have been describing throughout this video deprives the nail matrix, the tissue at the base of the nail responsible for producing new nail cells, of adequate blood supply. When that supply is insufficient, nail growth slows, nail quality deteriorates, and the nail thickens as cells pile up without the circulatory infrastructure to support normal turnover. Second, and this is the part that most people do not know, elevated blood sugar creates an environment in which fungal organisms, which feed on glucose and thrive in warm, enclosed spaces, proliferate abnormally. The combination of circulatory impairment and high glucose tissue environment makes the toenails extraordinarily vulnerable to fungal infection, and fungal toenail infection, onychomycosis, in an older adult with elevated blood sugar is not a cosmetic problem. It is an infection in a poorly perfused, immunocompromised extremity, and it can become a portal for the kind of secondary bacterial infection that leads to the wounds I described earlier. Here is why I placed this sign at number 1, because it is the sign that has the longest preclinical presence. Toenail changes of the kind I am describing develop slowly, over months to years, and they develop silently, without pain, without sensation, in a part of the body that many adults over 60 genuinely do not examine regularly or carefully. A study in the International Journal of Dermatology found that onychomycosis rates in adults over 60 with type 2 diabetes were dramatically elevated compared to the general population, and that the nail changes frequently predated the diabetes diagnosis by a significant margin. These were nails that had been changing for years while the blood sugar that was driving those changes went undetected. Eleanor was 74 years old, a retired librarian from outside Boston who described herself as meticulous about her health. She took her medications every day without fail, attended every scheduled appointment, ate carefully, walked regularly. She came to me for a cardiovascular consultation, and at the end of the examination, almost as a formality, I looked at her feet. Her toenails told a story that none of her other symptoms had: thick, yellowish, growing slowly. She told me she had assumed it was just what happened to toenails as you got older, that she had mentioned it once to a previous physician who had recommended an antifungal cream and not pursued it further. Her fasting glucose that morning was 198. She had been pre-diabetic for years and had crossed into frank diabetes without a single symptom she recognized as significant, while her toenails had been quietly narrating the entire progression. Tonight, after you finish this video, I want you to do one thing. Sit down somewhere with good light. Remove your socks and look at your feet with the attention they deserve. Look at the color of the skin around your ankles. Look at the texture of your heels. Look at the hair on your lower legs. Look at your toenails. Press gently on the skin of your feet and notice whether there is any area that feels numb or burns or does not quite feel the way skin is supposed to feel. This is not a medical examination. It is 5 minutes of attention. It is the kind of attention your feet have been waiting for, possibly for longer than you realize. If you find anything that resonates with what I have described today, do not wait for your next scheduled physical to mention it. Call your doctor's office and ask specifically for a fasting blood glucose test and a hemoglobin A1C. These are simple, inexpensive blood tests. They take minutes, and they can tell you with great precision whether your blood sugar has been elevated and for how long. The window between early detection and serious complication is wide and forgiving. The window between late detection and serious complication is not. I want to close by saying something to you that I mean with the full weight of 18 years of sitting across from patients who wished they had known sooner. Your feet have been carrying you your entire life. Every mile you have walked, every floor you have stood on, every morning you have gotten up and kept going, your feet have been underneath all of it. They deserve 5 minutes of your attention tonight. They may have been trying to get it for longer than either of us knows. Share this video with someone who needs it, not with alarm, but with care, with the quiet insistence of someone who loves another person enough to say, sit down, take off your socks, and watch this with me. I am Dr. Pablo. I will see you in the next video.